Mental health is very important. I had a question, and I'm saying this without fear. When I had the president talking about, ATI at the memorial, his family, and I know that he represented him at some stage. He knew that he had all these problems. He knew. Yeah, his family, he was his advocate when he went to court. Isn't that a wake-up call that thinks something needs to be done?
Something is going on. And today we are going to be exploring the mental health crisis. We bring to you an expert from Botswana, based in Australia, none other than Dr. Andrew Ntsowe. Welcome, Andrew.
Thank you. For the entire time that I've been a doctor and worked in psychiatry, the coordinators of mental health have not done anything to change the system. People don't think anyone is going to die from being mad or depressed or anything. People don't think mental illness kills. So
they say suicide, especially among the younger population, 15 to 29, is now the third largest killer in the world. So it's getting worse and worse. It's coming down in terms of age, isn't it? In terms of impact on. So I think your qualifications will be quite...
Sometimes it's okay to have suicidal thoughts so you don't feel so trapped in your illness, to know that you can actually escape this situation. They feel like there's no way out. This is the only thing that I can do. I think the other thing is the guilt that I talked about. I've done bad. I'm no use. I'm a burden. So I might as well just end my life so these people can be happy. With depression, the symptoms can be very, very subtle. And again, it goes back to the issue of culture. We're raised in the same generation where we didn't talk about our feelings.
Absolutely.
You wouldn't go to your mom or dad and say, I'm feeling sad.
Yeah.
They will give you a reason to be sad.
Welcome to the GrowthWell Podcast, where we tap into a well of knowledge, innovation, and leadership to fuel Africa's growth. Here, we explore thought-provoking insights and expert knowledge that empower individuals and businesses to thrive across the continent. Whether it's personal development or professional advancement, our conversations inspire action and impact. This is GrowthWell, where ideas flow and growth begins. Let's dive in.
Very sobering stuff that's been happening in the past couple of weeks. We had a very unfortunate event of news-making issue with ATI, issues of drug abuse and his death. And even at work this past week, we had an incident where one of my colleagues at work lost her 19-year-old nephew committing suicide just a week ago, just in the midst of the ATI story. So something is going on. And today we are going to be exploring the mental health crisis. Welcome to GrowthWell Podcast, the podcast that brings you insights, ideas that hopefully can make a difference to your world. So in this episode, we bring to you an expert from Botswana, based in Australia. Fortunately, he's local today. None other than Dr. Andrew Ntsowe. Welcome, Andrew.
Thank you. Thank you.
I'm telling you what is the second cabo that I'm having. Actually, it's not the second cabo. I don't know if you watch another podcast with Remo Lope. Remo Lope is a cabo from Muruleng on the South African side. We're talking about, he wrote a thing about Mzilikazi, a book about Mzilikazi. So you are the third cabo on the green seat.
We are coming strong.
Oh, there are more coming.
There are more we've just opened the gates for all of them.
No, thank you so much and welcome, Andrew. Andrew, you are, when I was going through your profile, you are a psychiatrist, psychotherapist, a bit of neuroscience. So I got a bit confused of that me weighing. So if you can just take the viewer, who is Ntsowe?
So Andrew is I'm a psychiatrist. That's my basic training.
Okay.
So did my medical training in South Africa and then worked a little bit in Botswana 5 years. Mm-hmm. And then After that, you have to go and specialize. I have always really wanted to do psychiatry. Psychiatry is the reason I did medicine in the first place. So I did that, just 5 years of training. So when I got to Australia, I had, before I could get into the actual training, I had to go through several exams. So those took a long time. There was a long waiting period before I could get into the next exam.
Okay.
So I used that time to do other things. So I did clinical neurosciences masters. I did
Clinical
neurosciences.
Neurosciences.
Yes,
Okay.
they call it Master of Brain and Mind Sciences, which is basically the brain, how the brain works and how it it influences behavior and society and other things. And then I did again. I actually did 2 masters at the same time. I was crazy. The irony of it. I was doing Master of Psychiatry at the same time as the Master of Clinical Neurosciences. And then I finished that, then did Master of Medicine in Psychotherapy.
Okay.
And then I went into my fellowship, which is the specialist training in psychiatry. In Australia, it takes 5 years. You do 3 years of basic training, and then you do extra 2 years of advanced training. So the advanced training, you can do it in different fields of psychiatry. Psychiatry as a specialty is broken down into different areas. You've got child and adolescent psychiatry. You've got forensic psychiatry. You've got medical psychiatry. They're just different branches. So or you can be a generalist, which is you do all of this. So I graduated as a generalist, but I was already a psychotherapist and a clinical neuroscientist. So I then did my concentration in youth mental health. And just 2 years back, I started developing interest in military psychiatry. And that stemmed from my training in trauma. I'm a trauma specialist as well.
Oh, okay, you're a trauma specialist as
yes.
well. In addition to youth mental health.
Yes. So I did training in trauma with the Boston University, the Trauma Research Foundation in America. So I was sort of fascinated by trauma, which is
fascinated by trauma.
Yeah.
Isn't that fascinating?
It's just fascinating, in a good way.
Yeah.
But it's because it's an area of mental health that is often not understood. And I would say that I can confidently say that I'm just going to put a number out of my body. I don't know how to say what part of my body. I'm going to put a number and say probably 80 to 90% of mental health problems are trauma-related.
Okay.
Yeah, and trauma is so misunderstood. People think trauma is, you go through a particular incident and then you suffer, PTSD, post-traumatic stress disorder, and those people who get caught up in burning buildings, rape victims and all the like.
Yes.
But trauma is...
And that's how I'm part of the lay people, so I see it as that's where trauma is.
Yes. And this word is used very loosely nowadays. One traumatized. People say that, and then people are arguing. People also saying get traumatized.
Yeah.
But there is trauma is what we've been talking about is what we call incidental trauma, which is there's been an incident, a particular incident that then affected your brain and your whole body and your mind. So it functions out of sync with each other. And then there's what we call cumulative trauma, which is there's a series of events throughout your life that sort of accumulated and became a massive big thing that then affects your ability to function fully
healthily.
And we call it developmental trauma. If it starts very early on in your development, and it's you sort of experience this throughout your development from your childhood right into your adulthood. So that's development. That is usually the most difficult type of trauma. Mind you, from childhood right up to age 25, your brain is still developing. The brain doesn't stop developing till after 25. So when you experience things when your brain is still developing, those things can shape how the brain develops.
Yes. Because it's not done in terms of its evolving and developing process.
Absolutely. And so some of the things that could happen to the brain is some of the essential processes that shape the brain to develop in a particular way may be affected, and people can develop, most mental health problems that we see. I've seen people who were given diagnosis, which I thought, okay, maybe schizophrenia, maybe bipolar, but trauma. And we see people who are then treated with medication and other things, but they are not getting better because we haven't dealt with the underlying issue. Trauma is treatable. And so it complicates mental health problems.
Okay. No.
But yeah.
No, great, Andrew. I think this is particularly relevant because we'll go through some of the statistics, but it is clear that now, if we go mental health deeper into, as an example, we were discussing suicide before we came. Increasingly, they say suicide, especially among the younger population, 15 to 29, is now the third largest killer in the world. So it's getting worse and worse. It's coming down in terms of age, isn't it? In terms of impact on it. So I think your qualifications will be quite... Before we get deeper, I like going into sort of a light moment.
Sure.
And we discussed that I'm someone who's into this happiness stuff. So I just like to you travel a lot. We're discussing how you are a Botswana, based in Australia, Sydney. You practice there. Sometimes you practice here with the different times. You also do, because of the internet, now you consult globally. So how it's interesting. How do you make sure that you stay on your top vitality as a psychiatrist?
How do I stay sane?
Exactly. How do you do it? So we can borrow some tips.
Look, it's psychiatry is, and it's disturbing that it's not common practice in most places, and I don't think it's happening here. Not here to attack any system in Botswana, but I don't think it's happening in our university. When we did our training, there was something called supervision. Supervision is basically you sit with a senior clinician. It was compulsory. As trainees, we had to have it once a week. With a senior clinician and offload and talk about stuff. And if they feel like you need help, then they'll direct you to help. I think it trains us to know that we can talk to someone. So even now, I would regard myself as fairly senior as a clinician, but I still have people more senior than me who I talk to. I meet with my supervisor every month.
Really?
Yeah, and if I feel like, okay, I've spoken to this patient, that thing touched me, I feel emotional. I need to offload. I'll call him and say, can we have a meeting? And then offload. We also have what we call peer review groups, which are also a compulsory part of our training, endorsed by the College of Psychiatry in Australia. So every practicing psychiatrist should have a peer review group where you meet, whether it's every fortnight, and you discuss things that are bothering you and stuff. Because we are not immune to these things.
Absolutely. Dealing with trauma must be traumatic.
It is. I was about to say that. You are so learned. You are ahead of me. You are ahead of me. So there's something called vicarious trauma.
Okay.
Which is part of cumulative trauma. This is when you're exposed to trauma stories. Just listening to stories, it is traumatizing. So without going really deep, we have certain cells in our brains, there's somewhere here, that are called mirror neurons. So basically what mirror neurons is, they just mirror the action or activity of the person you're interacting with.
Okay.
So if we were under some kind of brain imaging, usually MRI scanning, functional MRI scanning, which sort of detects the activity of the brain while we're performing a particular action. If you were watching me read from my book like this, the part of my brain that lights up when I read will light up in your brain too.
Really?
Because just from you watching me perform this. So mirror neurons are great, but they also can they can make us really vulnerable, or they actually do make us vulnerable in that us witnessing certain things affect us in so many ways. And a lot of research has been done around that. Like there is a certain degree of brain involvement, or different degrees of brain involvement, by way of mirror neurons, while you are exposed to different situations. For example, say I'm exposed to, so I'm told about the death of someone I don't know. I'm going to feel, as humans, we don't like people dying.
Yeah,
I'm going to feel like, oh, that's sad. But it doesn't really.
It doesn't go deep,
Yeah. And then a friend, maybe someone that I went to school with, they were in a different class, may affect me, but not as much. But someone that was in the same class with me, it will affect me fairly, provided I like them. And then, a close friend, even more, a sibling, was a parent, more a spouse, even more. But the mother usually is, it tends to affect people more, the loss of a mother. So, this vicarious trauma is a thing. So it does affect. I get affected too, but I take it somewhere else and just load it there until I'm empty and ready to go again.
But it's very helpful. It's very helpful.
Yeah.
No, great. So Ntsowe, as we are also taking away a little bit before the podcast about the situation in Botswana, where they are clear. I mean, just this year, I heard about a 10-year-old who committed suicide, in one of the nearby villages. Just this year, there was a businessman, 75 years old, who committed suicide. And talking to different people, everybody almost. So I just don't understand how looks like life is just normal, and why this podcast is also an instrument of agitating for certain things that I believe need to be attended. And as I researched on it with our team, it's not a Botswana thing. I know there's a global context, but Africa is really bad.
Yeah.
Southern Africa is really bad. When you look at Zimbabwe, you look at South Africa and all that. So they just really the first question for you is really what's going on? What's I don't know if there's a root cause. Yeah, what's going on?
Look, I think there's not one way of looking at it. I think it's a multifactorial kind of thing there. I think there are multiple factors, but we'll touch on some of them. But before I say that out, and I'm very careful when I say this, but I've held it in sometimes, but I've also decided to just say it and then get shot at if need be. Suicide is a terrible thing. I think almost every family has experienced some kind of suicide or an attempt. The way I look at it, this is very philosophical, and this is the sensitive thing that I'm going to say about it, is that suicide there are many different ways of dying. You can die from diseases, you can die from accidents, can get killed, murdered. And suicide is just one of those things, which is what I'm trying to say is it's part of being human. But it's also preventable. Like everything else that is human, that afflicts us as human beings, it can be prevented, and it can be prevented by identifying things that are likely to be risk factors and addressing them accordingly. So to go to your question, taking from what I just said, you are right. I think, like I said, it's a human thing. It happens in every society, in every race, every geographical area, but more in certain areas than others, which I was looking at the statistics when I got the questions actually. Lesotho has always been the highest, Lesotho. It's a very small country.
It's ridiculously high.
Yeah.
I mean, you're like, I don't want to stay there.
Yes. The suicide rate in Lesotho is really high.
Yeah, and 10 times the global average.
Yes.
It's really scary.
Yeah. And and then you have the St. Vincent's and the Grenadines. They've got the lowest, 0.41 per 100,000 population, which is
where is that
low.
again? Where is that?
I think it's in the somewhere in the islands,
yes,
in the Caribbean islands somewhere. So I think the other thing that I think also affects the statistics is the populations. Some country like Botswana, for example, we've got a very small population. So when statistics are sort of, done from that, our numbers are going to look higher than but still, for us, for that small population, those numbers actually
mean a lot. Yeah.
They mean a lot. They mean a lot. But one of the things that I think are the, perpetrators of suicide, like I said, it's multiple factors. I'd start with, I like grouping things. That's the easiest way to learn. So I'll start with personal factors. Personal factors range from different from different things. It could be things that are just yours. They're just about me that I probably can't share with some other people for some reason. Or I believe they're only affecting me. Most people actually, when things happen, they think they're the only ones who are affected by that, even if it may not be true. And personal factors could be diseases. Could be diseases. I mean, physical illnesses and mostly emotional illnesses or mental health problems. One of them being depression is the highest cost of suicide. And and this brings me to us noticing, that mental health problems are not so widely recognized in certain areas. If you look at the actual statistics and you look at all these countries that are affected by suicide and think about how much mental health is taken serious in those countries, I think you'd agree with me that not so much. Talking about something is one thing. Actively getting involved in doing something about it is another. You would think Botswana is a fairly sophisticated country in this area, and no offense to our neighbors, but we are. But still, the knowledge of mental health problems, right from top down there to the lowest levels is still very poor. And sometimes I watch comments on Facebook and watch the things people post and get really worried and go, is this our education system or what's going on? So personal factors. And then we have what I'd call community-related factors. There are things, and community, I'm not just talking about local communities in terms of Matubudukwane and the Matubudukwane community and stuff. I'm talking about communities, yes, that one, and there's Botswana as a whole. And then within this, there are certain communities like religious communities, certain groups and stuff like that. Communities or societal communities are also, they're contributory factors to suicide in them in many, many different ways. Just before this, we're having a chat about how religion, I'm talking about this, I'm a Christian, but I know that religion can be one of the contributing factors. We're talking about how most people who need help, for example, and people get me right, I'm not saying religion is wrong, it's very good. I'm just saying sometimes, and we have a lot of different churches, we've got a lot of different doctrines within churches.
Correct.
And so just depending on how that faith is delivered, that can actually affect certain people's mental health problems. Mind you, people who go to church, most of them are already struggling with issues.
Yes, with mental health issues.
Yeah, people are seeking
seeking some support.
Some place of refuge in church. And then the church can be brutally honest about some other things. They, of course, taken from the Bible, and it can, in some cases, sort of putting a lot of weight in how people think about themselves. The guilt that people feel from, believing that they are not doing the right things by way of their faith.
The sinning.
Yeah, I'm a sinner, I'm this, if you went and you did something and then you come back to yourself, we always come back to ourselves. That's the ultimate place we go to. You sit there and then you start thinking, am I worthy of being here? And then often there's a very poor meeting point between mental health and religion as well. Where if people come and see me, I focus on my medical training. And then they try to sort of talk about their faith beliefs. And I'm not going to, I listen, but I don't want to get interested in that. Also, depending on what I...
So there could be clash in terms of...
Most of the time there is a big clash.
Clinical approach plus the faith perspective.
100%. There is, and there shouldn't be, but there always is, because at the end of the day, it shouldn't really be about me. It's about the person sitting in front of me. ATI. It's not about me. It's not about you. It's about the people. So it's about the person who is sitting right in front of you and what they need at that time. But
so before you go to political issues, because you talked about the personal one, which we will revisit a little bit, and then also the knowledge base, as you said, Botswana is supposed to be quite sophisticated, but you get a bit surprised as to how these type of things seems to be fairly immature, how they're handled. And in terms of community, it's quite interesting because, and I like it because, I'm sure about Nturu sometimes. Nturu. Nturu. Sometimes I believe that we don't do enough research on social science, even social engineering, to really understand the root cause of the manifestations of our society. You got to admire the West. You got to admire the fact that, on researching about mental health, the first book and research that was published, titled Suicide, was by a French guy, Emmanuel Dequiem, in 1897.
Yes.
Where he analyzed.
That was my exam question.
Is it?
Yeah, that's my exam question.
1897, where he wrote about, and it's interesting that the things that I learned from him, for instance, was how modernization kills. And what I do is I juxtaposition our country in terms of modernization, managed modernization, the impacts of, and how it manifests in our mental disposition. And for me, without research, there's a correlation, because that's what he said. He said modernization kills. Even the most educated from his study were the ones who were committing most suicide. It was the Protestants more than the Catholics. It was the aristocrats versus so it was quite interesting.
Yeah, look, there's a high risk of suicide amongst doctors. And anesthetists high up there, GPs and psychiatrists.
Really?
Yeah. So, these are people who are meant to really understand this. So modernization does kill. And I like the way you use Botswana as an example. I often say we are, modernization is moving at a very fast pace. And, even though it's moving really fast, it's not really leaving our traditional beliefs and other things really that far. They're still with us. I still have the generations of my grandparents that are still alive with their beliefs and very influential in society. I still have my dad who comes from a different generation. He's 81. He's come from a different generation altogether. But he's still, his beliefs are still real than me. And I still have part of what I learned from my dad. And what I learned from my grandparents, I still have that in me. Plus what I learned, from modernization. And generations after me, they probably have a bit of what I have, a little bit of what they had from my grandparents, and then a lot of what they're getting from now. And then the current generations are moving really fast. And so we have a mix of all these generations in one with beliefs and different views around, health and health matters, mental health and all the like. And so these cause a clash. It's often very distinct. In Australia, I was talking about that to my team about the children of parents who migrated to Australia, who bring with them their own. They don't want to lose their culture. There's already been cultural dislocation. They left people there, their cultures, their beliefs, and they're there. And then they have kids there who are really Australian. Their culture is going to be Australian, but they also want to raise them. They don't want their kids to lose their culture.
Correct.
That causes a lot of mental health problems because kids often feel confused, around what to identify with.
Identity crisis.
Yeah, and that is, really a simple example of what is happening in our country where we have, identity, issues. So Matuke, where do they really fall? In terms of understanding, their current modern society, but also still having a bit of influence from their grandparents or great-grandparents. Nowadays, great-grandparents are not that old. People have kids really early, and then before you know it, you are a great-grandparent.
Absolutely.
So,
and the access to parents.
Yeah.
You might have even grannies and grandfathers.
Yes.
But because of societal change, our kids don't even have access to those kids.
They do not. I was raised by my grandmother, but how many kids are nowadays?
Absolutely.
So they live in the cities with their parents and Boneni. And so we are kind of in a bit of a crisis in that sense. And the other thing that I often talk about, which I wanted to leave for last, but I'll just touch on right now and maybe talk about it later, is something that in every presentation that I make to Africans, and sometimes I can be very daring. I've done that in Australia and put that up there and present it in a conference, is what I call the concept of decolonizing mental health or decolonizing health.
Okay.
It's a complicated thing, which is I'm Western trained. I also have the roots of my culture in me. So the language that I use on an everyday basis when I talk to my patients is colonial.
Correct.
Names of diseases, treatments are all colonial, which is foreign to our society. No matter how much we try to embrace it and make it a part of us, it's hard to get through to people when they're speaking a completely different language from what they believe. This is why AIDS nearly wiped us off, because we spend time debating language, where
when it was ravaging society. Yeah.
And then people were saying, Kibo Swahili, and then no, Hasibo Swahili ke AIDS, no, Kibo Swahili, Hasibo Swahili ke AIDS. We're debating language. The reality is we had something right in front of us. Call it whatever you want, but it's here. It's killing people. So I think I don't know how that's going to be done, but decolonization.
How does that impact on mental health, the decolonization aspect? I just want to appreciate your point there.
To me, is language is the most important form of human existence. If you don't have language, if you can't communicate, if you can't tell people how you are feeling and what you are feeling, or explain what's going on for you to people, it would be hard to survive in the world. So when I have a patient here in Botswana and they have schizophrenia and they sit here, I assess them, that's like interview but ultimately look at the mess of it. Ultimately, I have to write my notes in English. Why? Because we don't have a language to describe this.
Correct.
So after that, I have to talk to the patient and tell them what they have, and then tell them we have schizophrenia. It's a foreign term to them.
Yeah.
So what is schizophrenia? Now I have to explain it in Setswana. It doesn't become a name anymore. It's a whole description. which then...
And stay away from what peka kapo a
Yeah, malatsi a gate se ka re motho
o ska wa peka kapo a tsena.
Gate re mona le yeah. And these things, I think they are very complex because now you have to have this whole discussion with your patient about what they have. And then when you try to explain that this is what you have because of this, then you're describing something else to them. Then they tell you, no. These voices that I'm hearing, it's my ancestors are talking to me. That's the narrative in our culture. But you're seeing two cultures meeting, colonial and they're clashing, and
they're not helping.
Not helping
the mental. Yeah.
No, and the patient still lives. One of the things that people with mental health probably struggle with, especially schizophrenia, for example, is and bipolar and others, is what we call lack of insight into somebody's illness. There's a specific part of their brain that affects their ability to actually make sense of the fact that they have an illness. When they believe that DIS is following them, wants to kill them, they actually believe that. And it's real for them. And it's real for them.
They stay away from their houses and go hide in some villages.
They go and hide in a cave because they are hiding away from to them it's real. And so when you give them an explanation that doesn't make sense to them about what they have, they have to grapple with their illness and grapple with your explanation of what they have.
Just like other developed societies have. I mean, I'm sure in Japanese and Russian and
French,
and Chinese, French, they have their own versions. Yeah. So really, because why this is so relevant, is because I look at especially Southern Africa, the sub-Saharan Africa, because one of the things that I was going to touch with you is that you've got less sophisticated countries in Northern Africa, let's say the Arabic countries there.
Yeah.
It's amazing how they have much, much better sense of well-being, even if they are poorer.
Yeah.
And because they're very cultured, Arabic languages are very developed and they stay that culture. And I always say, as sub-Saharan Africa, as you said, colonization, maybe mismanaged. I mean, when you are describing the changing of from one generation to the next, and I'm just picturing a study. So why don't we study those things so that we proactively intervene? And then also I admire the West is because a lot of this stuff, you go back, philosophers and scientists, you can actually find written material. I know we came late in terms of the written language and all that, but it's not too late. Yeah. What are the universities of Botswana? What is the vets? What are the UCTs, the BUSTs and BTECANELO? What are they doing to help? Because for me, that is the long term when guys like you now start looking behind the scenes to say, what the hell is going on? Yeah. I'm staying away from because we'll talk about the politics. Remember, you want to go into the political sphere. Yeah. I wanted to first to focus on the issue itself, especially at personal level. Yeah. Because the next question I wanted to ask you is, because we're also educating our audience, how does mental health manifest? The key ones. You talked about depression. We talk about suicides, which I don't know whether that's the ultimate one. And then obviously there is anxiety. You talk about schizophrenia. Can you just explain a little bit? Because people are struggling at home, parents, youth, to see, sometimes these things are so common now. Even some of us who think are normal. My boys used to say, Papa, you're in a spectrum. I'm like, what is a spectrum? Because you was maybe issue. So now we are just help, just a normal person there to say this is obviously I'm sure it's a huge subject, but just pick to say typically ending up with suicide. These are the ones that get triggered by our current societal stuff that we talked about. Yeah.
Just before that, when you're talking about people thinking they might fall. So my godfather, my godfather is a white South African man.
Yeah.
Who I was with him in London. That they say, Andrew, do you think I'm normal? I said, Then I said, I don't want you to be normal. I said, I don't like normal people. Normal people make me scared. Why should people be normal?
Exactly.
And look, mental illness or mental health issues present in many different ways. There are different categories of mental illness, of course. I'll just talk about the broad groups of, but there is also an overlap of symptoms between these conditions, which sometimes get missed. So now we actually talk about something we call transdiagnostic factors. Symptoms that you can find this symptom, and it's there in general medicine. Fever can be a sign of infection. It can be just a sign of inflammation, which is not caused by infection. Mm-hmm. So headache, you can get headache with infections, with anything, with tiredness, with lack of sleep. So the symptoms can they can overlap. But we have, I start with what I call mood disorders. Mood disorders are, by way of class, conditions like depression, which affects your mood. The mood is the main symptom there. The low mood or just really depressed mood, and so mood disorders. Depression, you have bipolar affective disorder, which is, we used to call it bipolar mood disorder as well. And then, you can have anxiety. Sometimes it's classified on that, but it's a different category altogether, anxieties. So with depression, the symptoms can be very, very subtle for some people. And again, it goes back to the issue of culture. When I see someone from a non-Western culture who has depression, I open my eyes really wide to try and look for depression in places where it might not be found in this person. Mm-hmm. Because, for example, let's look at maybe our kids generations downwards, they're getting better at that. We were raised, you're older than me, you'd be, we're raised in the same generation where we didn't talk about our feelings.
Absolutely.
You wouldn't go to your mom or dad and say, I'm feeling sad. They will give you a reason to be sad. and give you why you said. I give you food, you've got everything.
Exactly.
And what are you sad about?
Yeah.
So we learned not to talk about feelings. And people say men, and even the women, we learned to, in the African culture, most African cultures, and I noticed the Chinese cultures and the Arabic cultures as well, we do what we call somatization, which is
somatization,
which is basically we present with physical symptoms that are actually not physical, they're actually mental.
Mm-hmm. Gotcha.
So these people often go to see GPs who are not trained to actually pick that this is prior depression. When I worked here, we used to have young adolescents come with chest pain. They usually would say, I've got pain, below my left breast, where they believe the heart is and where they feel that. And pain below the left breast, and then you check for everything as a doctor and examine, the heart is fine. They're talking about the emotional. That was actually my research, my master's research, which I did in Botswana. Interviewed 12 traditional healers to try and understand manifestation of mental illness and how they understand it themselves. And got to find that depression is really, a culture. The conclusion I drew from that is actually seen as a physical illness, or it manifests physically, but it's understood that it's a mental health problem.
Mental health, yeah.
Because the treatment then addresses the emotional part. So people are talking actually about the emotional heart. So, people talk about heartbreak. A symbol for love is a heart. People
are able to talk, it's not physical, or able to talk.
And they're like, so those things, then, I've had people about which, is we're trying to find language to describe exactly what we're feeling. But mostly people will just present with symptoms that really don't make any medical sense in terms of physical medicine. You examine the person, the heart is fine, everything's okay, you did x-rays. And, this is not to say that they're not feeling the pain. The pain is there, but what is this pain? The mind is connected to the body. The body is going to feel exactly what the mind is feeling, and interpret the way the mind is interpreting it. So the idea is to go just beyond, this is just pain, and go, okay, ask other things that that if this is depression, there'll also be this. There's this chest pain. I inquire, doesn't make medical sense. So then ask about things like sleep, appetite, weight loss, concentration, attention, memory problems. Then to those other psychosocial symptoms, isolating yourself from other people, not wanting to talk, not being very social anymore, feeling like you want to sleep all the time, or some people don't eat a lot. There are different types of, some people will eat a lot when they're depressed, some people don't. Some people sleep a lot, some people don't sleep at all. All those things, lessons for, as I said earlier, guilt, if it's come up through I think this is too much, I think I'm becoming a burden. Guilt that doesn't really seem to make sense. Guilt is not a bad thing. It's an important thing to have from time to time. It can come in handy, actually. But, guilt that doesn't really match the presentation, this person is just really, sounds like they're exaggerating their situation here. I'm terrible, this is why people don't like me, I don't think anyone likes me, and they can't really back that up with anything, any information. So I guess what I was trying to explain depression as it is likely to present in most African countries. And I'm also mindful of generational changes in that our kids nowadays get taught these things at school. They know what depression is. They can talk about sadness. They have counselors at school. They've got their guidance and counseling teachers who teach them these things. So they are more likely to speak a much more different language compared to ourselves.
Sure.
But you still get those somatization symptoms from time to time.
Okay.
So then we have bipolar affective disorder, which is people can swing between being really sad to being elevated and high when they haven't touched drugs. So when I started training, bipolar it was a cool diagnosis. I was shocked when I went to Australia and people were just really, every second person who's going through my door wanted to have bipolar.
Is it the one?
Yeah, like, I think I have bipolar, doc. I think I do have it. But it's an illness that I would never want to have because it's quite disruptive.
It's not very common, is it? I mean,
it's not as common as look. It's the prevalence of it is just 1% compared to that of schizophrenia. But if you look at the presentations that come and people who self-diagnose, now people don't want to have it anymore. They've shifted to ADHD. But now the bipolar, the mood swings, in bipolar are very different from mood swings where people will tell you, one moment I'm happy, one moment I'm angry, one moment that's something else that needs to be explored in its own right. But the mood swings in bipolar are such that people will feel depressed for prolonged periods of time. And I'm talking probably from a week to 2 weeks or more, or months. And then that alternating with periods of being elevated. And by the elevations there, I'm talking about not just I'm happy, I'm bubbly, just abnormal happiness, which is disruptive. They've got lots of energy. They can't sit down. They pace up and down. They clean up at night. They don't sleep. They've got no need for sleep in their own minds. I don't need to sleep. There's something about the phone is that these people will often really, I know that they used to really, when we used to have those landlines and have really make really big bills and calling people from all over the world and stuff. Because they're not sleeping and they're calling you at awkward hours. So they're elevated, they're like that, they've got an increased libido and sexual activity. They may start acting promiscuous, out of character. Someone that's just sleeping around. Men, usually common for men was that the other thing is overspending They just spend money. They go on shopping sprees and buy things they don't need, out of control, coming excited that they've bought this. Men would usually then overspend in brothels.
Oh,
and
it's part of bipolar.
Well, yeah, and we've actually not always. Not, sometimes it's just a habit or some addictions.
Yeah.
Or sex addiction. But in bipolar is more the symptoms sort of, you have them while you are elevated and manic. You say they're manic. They go around, they spend money. We've had to write letters to reverse some of the purchases people made. We can't go and argue with brothels because services were rendered. Look, unsex me, and you can. But with some purchases, we have written letters to reverse. People, maybe bought 3-4 cars at a go and stuff and spend lots of money. And this, what I'm saying, is disruptive. People find themselves in a lot of debt. They've made a fool of themselves. They've taken risks. They have actually got themselves in situations where it's hard to live. And then it worsens the depression of the bipolar.
Then it really gets out of...
Yeah, it's an episodic illness with more mania plus alternating with bipolar. Some people just have the mania, alternating with mania. Some people don't really get the depressive episode. They are more the manic episodes. And I don't know if I believe that. I think some people have different ways of experiencing depression. I think even if they didn't come to attention, I think people may have had some depressive moments and just really maybe dealt with them, because naturally depression will just get better even if it's not treated in some cases. So we then have what we call anxiety disorders.
Okay.
Anxiety disorders. Okay, before I got there, with the mania, with the elevations, we've got what we call hypomania. Hypomania is they're elevated but not
that high.
Usually not very disruptive. That one can come handy with some people because they will often they have energy, they can think really fast, they've got lots of ideas coming. They can actually do well in business engagements if it's not too disruptive.
I get you.
And this is why people hate not being manic, because being manic feels great. So it's often hard to treat them. This is why they don't take their medication, because once they are level, it doesn't feel right for them. So
let's summarize the anxiety. One is anxiety. The other one is
psychosis.
Psychosis.
Yeah.
Then we can deal with the suicide part, and then we can close.
Yeah. So anxiety. There are different types of anxiety. Anxiety is actually much more common than we realize. Everyone needs a little bit of anxiety. When I treat my patients, I tell them, I don't want to take away all of your anxiety. You're going to need some of it. Sometimes we need to be anxious when we have to be. If we're never anxious, we'll just get ourselves in a whole lot of troubles, because, the anxiety is that thing that goes, no, you can't do this. This is wrong. That's the thing that holds you back, that fear. Or I have an exam, I have to study, otherwise I'm going to fail. But it's bad if it interferes with your ability to function and affects different aspects of your functioning, personal, social, occupational, and otherwise. So there are different types of anxieties. There is, we have generalized anxiety disorder. These are people who just worry, constantly worrying about anything and everything. And you talk about this.
Why the price of petrol?
Why is this phone black? So they just worry about one thing and another, and can't switch off their brains. They're constantly going. They become tense, stressed, anxious.
The cortisol is always up and about.
And that's not good for the brain. And then they can't sleep and all that. So it can look like depression sometimes. And there have been debates about whether it's one and the same thing. There is what you call social anxiety, really being uncomfortable and anxious in social settings. You can't, you feel like you're going to make a fool of yourself in social settings, and you avoid those social settings. There is panic disorder, where you just out of the blue. As an analyst, I would say nothing is ever out of the blue. It's just, we just don't know yet what triggered that. But out of the blue, you just have massive panic attack. Your heart is pounding. feel like you're going to die. There's this sense of impending doom that, something terrible is going to happen or I'm going to die. Most people say I have a heart attack because the heart is pounding and then they can't breathe, they're sweating, they just collapse to the ground. So you can have a panic attack, 1 or 2, and may never have another one. You can have a panic attack in the context of social anxiety. You can have a panic attack in the context of generalized anxiety or depression or psychosis. But it's panic disorder if you have multiple panic attacks, say a week, more than 3, 4 panic attacks a week. That's when we label it. This is your diagnosis is panic disorder. Then you have phobias. There are different types. There's phobia for animals, phobias for bloods and other fluids. This person who just will have a panic attack just looking at blood. They can't be a doctor. And then phobia for snakes and for different things. There's agoraphobia, which is phobia for being in open spaces or different settings, which make you really anxious and stuff. Yeah. So anxiety is I think is the main symptom. It's usually very common in young people. And with anxiety, I think we're going to have more social. I think we already are having more of social anxiety, and I blame the phone, social media, and I think a lot of kids nowadays are now we're not learning how to interact socially. People interact now through gaming, through social media, Instagram, Facebook,
TikTok,
So that's where people talk. And then when they are meant to actually come together and socialize, they don't know what to do. So I think it's going to get worse in the next. It's going to be our next pandemic.
I agree.
And then we have psychosis. Psychosis is madness. Madness. It is. So, and these are people who lose touch with reality. The brain is not functioning okay for many different reasons. In the brain, we've got chemicals that are meant to actually get nerves performing certain functions. If they are not, the nerves are not firing okay, these chemicals are not produced, in the right amounts, that can disturb, brain function, and people will start hearing voices of people when there's no one around. And I always tell people, stop saying that's really creating a completely complex narrative. Those with the voices in their nature are actual people's own thoughts, which are then distorted by the illness. So and you can see things that are not there. People can start seeing, seeing ghosts, seeing DIS trying to kill them. People become delusional and think that people want to kill them. Or aliens are following them. And it is, to them, it's real. And it's traumatic. Just imagine if aliens were indeed chasing you all over Gaborone, how scary that would be. And to these people, it's real, it's happening. So you can imagine the trauma and the PTSD that comes with the psychosis as well. And then there's a whole range of other conditions. We've got personality disorders. I gave a lecture on personality disorders.
Okay.
We have eating disorders, and then we've got substance use disorders, and all the others.
Which is the addictions and
addictions,
all that.
yes.
Yeah.
And addictions are many. I know most of the time people focus on the chemical addictions. There are also there's gambling, which is a problem, which is will often worsen addiction to other chemicals. You lose money, you are stressed.
Then the whiskey is always next door there at the gambling thing. Yeah.
And then, sex addiction is often not talked about. I see it a lot in my rooms. It's a thing.
And with the readily available porn channels, that makes it worse as well.
It makes it worse. And now it's one of those things that it's a taboo subject. It doesn't get talked about. So it's almost like it's not happening, but it's, it's there. And even as a psychiatrist, you have to be really tuned in to actually, see that, okay, this is what is happening here.
Let me ask you a silly question.
I like silly questions.
Are we making this a big deal, but that's just how life it is? I mean, sex addiction was then 2,500 5 years ago. There were brothels. There was drinking. Are we trying to make an utopia out of something that's not meant to be?
Like
I know that affects your job, but
he just took away all my clients. So you mean medicalizing real life situations?
Yes, real life. Yes. I mean, I always say life is about yin and yang. You always have. You need to have good. You need to have bad. To have wife, you need to have husband. Mm-hmm. To have hungry, you need to have food. You need everything has to be, and just how the energy is designed.
Yeah. To answer that, I say yes and no. Mm-hmm. You know, the yes part is, I think there's now over medicalization of things that are normal. For example, grief. Mm. Grief is normal. You know, you have to grieve when you've lost someone that you love. You have to cry and feel sad and feel miserable. It's not a disease. It doesn't need treatment.
It's a human condition.
It's a human condition. Doesn't need treatment. The question is, what does someone who is grieving really need? They need to be with people that they love.
Absolutely. Which traditionally, after bereavement, a whole family will be with you for 2-3 weeks just to support you to go through the difficult time. And
grief is worse in the West, where people are more individualistic. You know, here we still have to, so people come, they move in and then they'll move out after, one by one. So, no, in that, yes, some of these things are a part of life. You know, why is drinking and going to a brothel and having fun an issue?
Exactly.
Why is being addicted to sex an issue?
Big deal, yes. So long as it's safe for everybody.
So it is a problem for some people, because then they
become dysfunctional, or they become dysfunctional in society. Is that
100%? And then, a real sex addictions, for example, people start doing things like masturbating in public, or trying to touch other people, or not having those boundaries. So this is where, when it affects you and other people,
that's correct.
Negatively, that's when it becomes a problem.
Now let's go back to those conditions of mental health, because the ultimate one is now where someone decides to take their lives. And it's also related to the question I asked, Jorge. People, stoics, the samurais, killing oneself. It's in some cultures. It's a disciplined way of showing I'm exiting because courage. I've done bad. I have courage and stuff like that. So, but we believe that it is actually above normal, whatever normal is, and it's painful, to have, especially kids who currently seems to be a bit of a pandemic globally. So, how do those now lead to? I know it's a very difficult question. Lead to someone to decide to exit?
You're right. It's a very complex question. And like I said earlier, suicide is another human condition, really, that I don't think we're ever going to abolish it, but we can manage it and reduce the numbers and probably learn from those who have done better. But these conditions, mental health conditions, really, you need your mentation to navigate life. You need to be mentally sound to navigate life and survive and do things. So if your mind is overwhelmed with all this negativity that comes from your illness, it's really hard for people to actually see a way out of that. Look, for some, and this is a discussion that I have with my patients sometimes in therapy who are suicidal, and it's been going on for some time, when I say sometimes it's okay to have suicidal thoughts, so you don't feel so trapped in your illness, to know that you can actually escape this situation. It sounds creepy, but having that knowledge that there is actually an outlet, it offers some sense of relief, some kind of relief for some people. They don't feel trapped. They then go, okay, there is this, but I don't want to do it. I can talk to someone. Oh, I shouldn't be doing it. I can talk to someone. And then, but depression, let me start with depression, because it's the commonest cause of suicide.
Okay.
Depression basically just saddens people. People become extremely sad. So sad that life loses meaning. They look around, everything is just dark.
Everything meaningless.
meaningless. There's no point going on. I can't. And people who are depressed often don't seem to think that it's going to end. They will tell you that days are really long, and it doesn't seem like this is going to end. It's like this is the end of me. And often, when depression is actually quite severe, it also affects what you call cognition, which is your attention, concentration, memory, ability to plan, problem solving. Those are affected. They're dampened down. So you're operating at a survival level. Your thinking brain is offline.
This prefrontal cortex doesn't.
It's offline.
The CEO of the brain doesn't function.
So there's no thinking about consequence and what would happen. You're just focusing on the pain and how to get out of the pain. And for some people, it's hard because we never really interviewed those people.
That's the thing. I mean, I'm really thinking that was like we've never been there, but it doesn't stop us from thinking. I mean, you always think just moments before they decided what was going on. Yeah.
Look, for those who tried and failed,
they can
give
testify.
us a bit of testify that look, this at that time, that's how I felt, and people at that time don't really care. They feel like there's no way out. This is the only thing that I can do. And there are different causes of suicide. Some people, I think the other thing is the guilt that I talked about. I've done bad. I'm no use. I'm a burden. So I might as well just end my life so these people can be happy. Some people would feel like there is a punishment for something they've done. They deserve punishment. Yeah. Some people will feel like it's evade justice. I've just killed someone, so I know what's going to happen, so I'm going to kill myself.
Or typical of GBVs, gender-based violence. A lot of these men that kill wives or girlfriends
and then kill themselves. Yeah. So some of them is more of I know what's going to happen.
Yeah.
They know that they're not going to be able to live with the consequences of it, even if they went to jail. And so depression is the commonest cause. I think for me, it's more the brain's functions are really dampened down to sadness, which is viewed as this is where I end. I can't really escape this. And so we often really inquire a lot into suicide and do risk assessments for people who are depressed. We should do for everyone, really.
Yeah.
Psychosis is the other cause of suicide. For different reasons, there's actually a much higher risk of psychosis, of suicide with psychosis than people realize, especially schizophrenia. One of the causes of that could be hearing voices that actually instruct you to kill yourself. Some people have that. So we call them command hallucinations, which literally constantly say, you need to kill yourself, you need to do this. And I've never had voices, but from what patients tell me, they're so insistent and so believable, so real, that acting on that is the only way out. That if you try to distract yourself, the voices just constantly, some of them are nasty and yelling at you, you're good for nothing, look at you, you're mad, you kill yourself. And some people actually do that under the instruction of the voices in psychosis. Some of them, it's an old term that, hardly ever gets used. I still use it because probably I'm old. It's called post-psychotic depression. Post-psychotic depression. Someone has been psychotic. When you are psychotic, most of the time, people do things that are out of character. You may take off your clothes and run more CBD naked. Or people just do really things that are sort of shameful. And then when you come to, and people believe that people who are mentally ill don't remember. I've had people say, how come he remembers everything that he did when he was mad?
Clearly he was not mad,
Yeah. And that's a fallacy. They are mad, but they are not stupid. They are not demented. They'll remember things. Not some, but a lot of things. So people remember that they were doing things that are out of character. They then become depressed from that, or they look at it from, this is going to be my trajectory. If this is my trajectory, then I might as well just check out. Very high risk groups are young males, also with substance use.
The substance use makes it worse.
Makes it worse.
Makes psychosis.
Because it takes away the natural human inhibitions to stop yourself from doing things.
Yeah.
I mean, house no bit, you can tell people, you can fly. The next thing you're jumping off the
roof or something.
So that's that. And then anxiety can cause suicide, especially if it's really severe. Like OCD used to be labeled one of the obsessive compulsive disorder, which is people washing their hands or have these compulsions that they have to act on, obsession that they have to act on. And some anxiety disorders can actually lead to that. Personality disorders, especially the sort of the so-called dramatic personalities, which are there are 10 listed pathological personality disorders. There's cluster A, which is they're called odd. There's B, there's C, which are anxious. The B's are dramatic. These are the narcissistic personality disorder, antisocial personality disorder, borderline personality disorder, histrionic personality. So these two, histrionic and borderline, are also more prone to suicide. Yeah, and they would often, most of the time, are seen to be crying wolf. These are people who take multiple overdoses several times, and people just go, "Oh, abanzan with bidis," and then eventually they do it. It's almost like a stepwise approach to suicide. So, it's complex. And speaking about the causes, I think the other thing that I think needs to be researched really intensely is the meta-suicide complex, which is called the passion killing.
The passion killings.
Yeah,
this is the GBV ones.
Yeah. So it needs to be really researched quite intensely. And I think we talk about it more in an over-sensationalized manner than actually do anything about it.
Absolutely. Look, it's not just, you come at GBV. The same region has got the highest occurrences of rape.
Yeah.
This is,
again, environment and
exactly. So they're all related. And as you said, we need, like a census, the papers, the politicians talk about it, but some of us wonder what's actually going on.
Yeah.
What's the psycho behind these behaviors? Could we find a connection? And it just leads me to my next question, Doc. You touched on it, and I'm just extrapolating what you said, because it's the cultural clash. And one of the things that I've said, and from my research, is that we're finding that because even the developed world is battling with some of these issues, as you might be aware. The States is battling with addiction issues, it's battling with even young people in terms of suicides, especially for men and young men. Young men are really, really struggling, and you might touch on why specifically for men. But we're talking about young men. 3 weeks ago, I went to a cultural event in Hamaliti, where Bafana Nabaile Bukhuera for 4 weeks. Yeah, for 4 weeks. For 4 weeks. And listening or checking out these anthropologists about how, with the well-being disaster, they're now trying to borrow and learn from ancient African cultures. I talk about the Hansa tribe, the old tribe in Tanzania, where these top universities are learning from them in terms of social well-being, even body well-being, how to maintain good bodies and stuff like that. And I say, but this is us. What are we losing from a cultural point of view that was actually important in terms of maintaining well-being, discipline, grit, and all that in our boys? Because these boys just spent, a whole 4 weeks in the bush, harsh conditions, so that they can learn to say, because these days we find that, young men and young ladies, every little thing just depresses them. Because we've been bitten, we've had this where you had rain and you've done all these harsh things, and you tend to think anything can come by. So what are your thoughts around this rites of passage initiations like Bokhwera and Bojala, which is very much still practiced by lots of tribes in Africa in terms of African education, obviously modified. You're talking about circumcision there. I could tell, but I'm more interested in the education of creating gritty and stronger well-being and mental health type proposition.
That's a very important point, and that aligns well with the whole concept of decolonizing health and decolonizing our culture. And I'm not saying we should try and lag behind developments and modernization. I'm just saying, can we use what we have to enrich our own
same thing.
welfare?
I'm not saying the same thing as I'm saying, can we pick the stuff that can still work for us?
Yeah, absolutely. And just really use it. My view is, I think culture had a very, very important role in shaping people's mental health. So, look, psychiatry is a very culture-specific discipline, and people don't, for example, get mad, about something that is completely outside of their culture. Makwa will talk about there's a chip in my brain, but So these things, these cultural initiations and stuff, they had a role. Let me start with just Botswana.
Okay.
So there's something called attachment. So attachment is a very important concept when you have, after a baby is born, the mother needs to bond with the baby. And it's a very important neurobiological and psychological process. The mother talking to the baby, that gaze between the mom and the baby, and then mother talking in a particular way to the baby. People said, why are you talking like that? That's very important. Those things, that's the process of attachment, which shapes the person that you are going to become an adult. And attachment, actually, I think I've got one of our presentations by the end of the day is going to be attachment and consequent adult relationships.
Okay.
Your attachment style determines the kind of person you're going to be in a relationship.
So secure, avoidance, and what's the other one?
Dismissal.
Yeah.
So you have, Botswana was it's a very important thing. When I went to Australia in my early years of doing my specialization, I was looking at, the borderline personality disorder, which is, in it, there's a lot of attachment problems there. It's very common in the West. We're getting it now here, because I had never seen so much of it here. When I got there, people had this condition. It was one patient after the other, cutting themselves, taking overdoses. And then, one day in our class, we were talking about this, and then I was with my cousin in the same class, with Dr. Radebe, who then said, we don't have borderline personality disorder in Botswana. I said, I think we do, but it presents differently, but it's just much more severe here. So in my opinion, I think the attachment process in the Western society has gone completely flawed. I think, and they used to do the same thing that we used to do.
That's interesting. Yes, way back they used to do the same thing, isn't it? Yeah.
Yes, and they stopped it. And then the problem is that we're copying everything from them.
That's the problem. You can say that again.
Yeah, we think
we just did cut and paste when they've actually gone out of order.
They have. And we also need to remember that these people they are imitation. No, they are. It's science. It's science. The original, human gene is black. The white gene is a mutation of the black gene. It's science. So, but we tend to copy people who are clearly not the original. Sorry, people. But, and we copy them. But Botswana had a role. One, you lying there, given a chance to bond with the baby. And then Botswana takes over the other roles, we run on as excuse from this, so they can have time to bond with the baby. And they would often be coached on how to do that if it's the first time. They are coached to do this, do that. My mother used to say to my sister, all those things. And we're losing that here. So now we are in the cities. You know, and then and we're also working. So now you come back from work, you are tired. She's tired because she's been looking after the baby all day. So I want to hold the baby and let you have some rest and sleep. So it disrupts attachment. I think it's going to be one of the causes of mental health problems because, you know, now I have...
Right from source.
Yes.
Right from source.
Yeah, right there. And then, you know, development throughout the lifespan, there were ways in which we were raised. You know, some of them were questionable, like Musimana Khadli, and the like, but they served a purpose at the time.
Isn't it fascinating that, as you said, you know, I watch families and, you know, even from, you know, what we categorize as, you know, low class and then, you know, top, middle, upper class, you know, city-like. And you'll see a family that was grounded on the culture. You know, like with those aspects, and then even if they end up being emodisa, but you can see this is a straight boy.
Yeah.
Am I right?
Yes.
Straight boy.
Yeah.
And then you compare with the same age, growing a sita, and sort of to see, messed up boy.
Yeah.
Am I right? You can see these are two different worlds, you know, coming up with two different citizens because of just a cultural component. And this one is growing exponentially while this one is busy fading away.
Yeah, 100%. And I admire most of the people who, like when I went to school and the like, and look at them, the men that they are to their wives,
might be a security
families.
guard in my body. So this maybe when you sit with them, collected, disciplined, family person, knows the rules at home. I learned a lot from both driver, both Matlinara, Marina. Went to the houses, they're building a big house, and family. That discipline, you know, it speaks to something. And meanwhile, I was a doctor, but I couldn't keep my budget under control. You know, I was going around and like, why can't I build the same house? You know, so Bobuhuera, you know, I think now a few times we've gone send people to Moruleng because Khosi go Moruleng to Cape Town now to do that. That there is for both men and women the initiation. Although yes,
I think most of a lot of what happened there was this actual initiation into womanhood, into manhood, and, you know, some degree of responsibility, like you said. Who you know, starting from Kodisa Dipotane and all those things where you feel responsible. You know that you are responsible for these things. You know that someone needs to do this and this got to be me. You know, and you sort of pass that on to your kids. And I had Kobohuera, I haven't gone. You know, I wanted to, then I was told that I can't. But most of the things that these guys learn there also is being taught on how to be a man.
Absolutely, yeah.
You know, how to be, you know, to be the head of the family. You know, a language that we don't want to say that anymore because it's challenged. And women, the same thing, how to be a wife and how to be a mother. So you then are going to have men who don't have low self-esteem, who are confident being men because they've been initiated into being men. They are comfortable with who they are.
Practiced, disciplined men. The other thing is that the role models are actually the ones who are coaching and mentoring them.
Yeah. And they're not going to be intimidated by their woman asking a question, a wife asking a question. They still know who they are, what their position is in the family. Whereas you have me who's not hasn't had that initiation. And then the moment, you know, my wife says something, then I want to, you know, one challenge, who do you think I'm not a man enough? So everyone knows the roles are well defined and they are taught, you know, separately, properly by people who actually know what they are doing. I think I'm interested. It's just that we don't have the right archives, but research can still be done in people who actually have done, countries that still really follow this culture.
Correct,
and that having done and make comparisons. In my opinion, I think this would help.
You think it will help?
Because there is a certain type of responsibility that a man entrusts with himself after they've gone to initiation school.
Yeah.
People who haven't gone there. So, how are you? There are certain things you don't. But this sense of responsibility, I'm recognized as a man, and I can actually participate in certain discussions. Yeah. It boosts your self-esteem.
I'm part of Mopato.
And I'm part of Mopato. I belong.
Yes, actually you're right. Sense of belonging.
Yeah, I belong. And so...
That's powerful mental health-wise.
It is. It's very powerful. And your self-esteem isn't ever in question. And...
Also it fights the whole hyper-individualistic world of the Western world.
Yes. So the problem with the Western world that we actually are now so indulgent, is Rona, we live in the Western world that was lived by them 10 years ago. Yeah. We're still behind them.
Yeah.
And but then we see something different on TV, on social media from what we're doing, and we try to be that while we are really here. How can I live that life when I am actually still probably 10 years backwards from that life?
And then it triggers things.
Yes.
It triggers things.
Yeah, there is going to be that it disturbs identity, it disturbs the sense of self, it disturbs how you view yourself. It's almost like you're chasing something that you're chasing some kind of meaning, but you don't really know what that is.
Just we don't want to leave. Remember, you were touching on politics earlier, and we sort of left it hanging. So back to it, because the feeling is that this whole mental health story it's running out of control.
Yeah.
We whether we're in a crisis or pre-crisis, whatnot. And I just want you I always ask experts when they come here, what have you done about it? And stop complaining. And obviously I'm looking at the entire ecosystem from the political to the ministry to experts. We were talking about SADC and all that kind of stuff at a regional level. So what do you believe are the current strategies that are working and the ones that are not working? And after that, as we work towards the end, then we'll finish with the question of now, if you were to arrange for you to meet with President Duma, what would you say, Mr. Duma? These are the two things that, if we don't do this,
I'm not coming back.
Yeah, I'm not coming back, exactly. Yes.
Look, that's the first question. Like, what's working?
Yeah, right now, what are we doing? Do you think it's working? Do you think it's going to reverse the thing? And
I think Botswana started off okay, and interestingly, when the mental health system was run by psychiatric nurses, I think a lot of things worked. There was a time when psychiatric nurses were like the people I was inspired by a psychiatric nurse to be a psychiatrist. They used to go around doing outreaches and, they still do, but they're hindered by the government. I'm saying it, I'm not afraid. And they used to do that. And
you're not talking about my people, are you?
No, psychiatric nurses.
Real psychiatric qualified nurses.
Qualified nurses who have gone and done general nursing.
Okay.
Go IHS and then went back to about a specialization in psychiatric nursing, who a lot of them actually even way better than doctors in psychiatry. And so there was that spirit where they'd go and you have a psychiatric nurse, they do assessments, they initiate treatments. And, of course, we didn't have a psychiatrist at the time. And we ended up having mainly foreign psychiatrists. When I went to school, I was the first person to receive a government scholarship to psychiatry.
Really?
And that was in 2005.
That's recent.
Yeah. And so... but then other people were outside doing it, trying to do psychiatry. We've got, people who graduated before me. But it goes to show You're not going to convince me that all these years since the government started sending people to school and to specialize, they didn't see the need that they should actually try to push psychiatry. It's often put in the back burner. Psychiatry is never taken serious. Mental health issues are, unfortunately, throughout the world, not taken very serious. I saw the other question was on budgeting. The budgeting is often very small. Now, this is the one thing that I'd never understand that frustrates me to the core. The government will take nurses, train them in psychiatric nursing, which is a lot of money for the government, the taxpayers' money. Then they go back to work, but as psychiatric nurse, but my maternity ward. But I'm midwife, but my doesn't make sense to me. I've never understood this at all. And as a psychiatrist, I'd like to work with a psychiatric nurse because I'm confident that if I'm not there, they'll do the right job.
Yeah.
So it's still happening. It doesn't. I don't think there's any reason for it. It's more of they argue that no, they should be able to work anyway. But they are specialized.
Sure.
So would this help? If they really focus on psychiatry, would that help? It would. And psychiatric services should be enhanced. Take Gaborone, for example. This capital city of Botswana. There's no psychiatric unit. You can't admit anyone for psychiatric illness.
In any hospital.
So no.
You have to go to Lubats.
And that doesn't make sense to me.
70 kilometers away.
Yeah. It doesn't. So putting people's lives at risk and the patient's life at risk because you have to sedate them. In the emergency department, you have to sedate them heavily, put them in a car with a nurse sometimes the police would help, to Sabrana. Why don't we have a psychiatric unit in Gaborone? Because people don't think anyone is going to die from being mad or depressed or anything. People don't think mental illness kills. So people think they need to prioritize physical illness. Because if you walked into the ED emergency department and you were mad and psychotic and screaming and yelling and hearing voices and you are Jesus Christ or Michael Jackson, and then somebody came, they've got abdominal pains, they'll attend to that one because they're going to die. This one might not die until he does.
Which talks to education as well, that you actually just the knowledge and the understanding of mental health, again, seems not to be...
It's poor. It's poor. So the notion that we don't have a psychiatric unit in a capital city
says a lot.
And then...
At policy level, I'm just interested, at policy level, do you think we have the right stuff in place?
No, I really think we've got really questionable characters in the... So we had... I think first of all, I think we should have in the ministry, there is actually a little section, it's mental health.
Mental health, yeah.
Usually it's run by a psychiatric nurse. And look, I don't care who runs it. I don't want it to be run by, necessarily want to be run by a doctor. I just want it to be run by somebody who knows what they are doing, what mental health is and what the people need, in terms of their mental health needs. That, just putting someone there just because you want to put them, because they applied. I can't say I've seen them do anything. I'm sorry, people. You haven't done anything, for the entire time that I've been a doctor and worked in psychiatry. The coordinators of mental health have not done anything to change the system,
Is it incapacitated? Is it not, again, going back to budget for mental health? Yeah. Or it's too small, too ineffective, not enough skills? What is the problem there?
Sometimes you need to advocate. You need to be that man who's going to make noise. We're talking about what have people done. I'm not here to blow my own horn. In 2006, going into 7. Well, since I started, I went to Lubats 2005. After it was a fight for me to go there. We've got a young doctor who's saying, I want to do psychiatry. There's no local psychiatrist. And then they were giving me hell to do that. So I usually would not keep quiet. So I then went there. And then when I got there, I won't talk about the other things that are too sensitive. But one thing that I went there that I noticed was we're still using some of the oldest medications that, they work. They have side effects too. We have other options, and people can still, the old ones, I still use them now in Australia from time to time, but there are newer ones. And I spoke to the then boss of myself. I said, we need to, in South Africa, they were still using new ones. And then he said, I've spoken to the ministry. And then I felt like, I don't think he has. And then I pushed, and then nothing was happening until I became very dramatic. I was young and full of drama. I did. And then,
threw some tantrums, yeah.
I did. So I ended up taking it to the media, as a way no one was going to listen. So I took it to the media. And then literally, I did my tricks and then got someone from BTV come get permission from the ministry. I got permission from the ministry, and then we're interviewed by BTV, and I said it like it is. That we have these medications. The old ones, I'm not saying they're bad. I'm saying they're bad if they're the only option we have. Because if someone can't have them, then what's left of them and their illness? Some of them will experience side effects that are worse than madness. I'd rather be mad than have those side effects where I can't function at all. So I nearly got in trouble. Of course, I was prepared. I didn't care whether they fired me because I wasn't government-sponsored to do my medicine. So we went to the ministry, and then there was this talk, oh, no, you shouldn't have gone public. I said, I tried to talk behind the scenes.
But
I think
it didn't work.
It didn't work. So you know what? So I went to Australia, and then 2 months later, I got an email, someone saying, we've got new drugs now.
Wow. It worked.
It worked. They are there. So, but do we have to be dramatic for things to happen? So that, I think a lot of things need to change. I don't think people understand mental health, but I also want to blame, with care, my colleagues, to blame mental health clinicians, and also recognize that mental health was run by nurses for a long time, and no one respect nurses. So they were not. I don't think they'd be listened to if their voice would be heard. If they said, "Look, we need to do this," so and there were few psychiatric nurses, but now the numbers are many. We've got not only mental health nurses, we've got psychologists, occupational therapists, mental health social workers. We now have psychiatrists who are local. Group up and speak in one voice.
Yeah.
Rather than sort of go there and then want to be promoted to the ministry to then go and do nothing. I feel like we're failing our community because I still support a lot of nurses from Australia, from mental health nurses who work in very remote areas of Botswana.
Okay.
Who they've got my number. They'll call me and say, I've got a patient, they've got this, they need this, what should I do? And then I'll give them instructions to 1, 2, 3. And most of the time they're doing a great job. But it's sad when they want to help, and most of the time their hearts are bleeding. They really want to help that patient, but there's no medication. The police are standing there and saying, if you don't inject this person, we can't take them to the hospital.
But there's no medication.
Yeah. So I think there needs to be an association. I don't think there is any, where mental health clinicians need to come together and speak in one voice and advocate very strongly without fear. And what would I say to President Boko if he came here?
Yeah.
With the minister. I know what when I saw that question,
yeah,
in my head, I laughed. I said, I'd say, fire the minister. Start with that. But I would say mental health is very important. And I think most people don't realize that, I had a question, and I'm saying this without fear, when I had the president talking about, ATI at the memorial, his family, and I know that he represented him at some stage. He knew that he had all these problems.
The president knew.
He knew
that ATI had all these.
His family. He was his advocate when he went to court. Isn't that a wake-up call that thinks something needs to be done? Anyway, I'll just cut him some slack. He just got in. I'll be watching. But something needs to be done. We need to change the way our mental health system. We need to have a real representation in the ministry. There isn't any. You can't have one person and call them a coordinator of mental health. Just one person coordinating mental health throughout. There need to be a committee of people with all cadres represented in the ministry. Secondly, I don't understand why mental health is under public health. It does not make sense. If you're going to argue that it's a public health issue, I'd argue that diabetes is too, and so is hypertension, so is infectious disease. They are public health issues. Why don't general medicine then fall under public health? Mental health and psychiatry is a specialty, it's a specialization in its own right. So until people see it as that, we're not going to progress, because people see it as a little branch of public health. It's not. It's far from that.
There's so much emphasis on non-communicable diseases. Your diabetes, your cancer, and all that kind of stuff. Yeah. And as you said, the mental health is sort of foginyana. We don't know where it fits. Like I was talking about Marina right now. There was a small clinic in Marina, behind Marina. And then there was a problem with the building. They moved it, and then it's in Block 6. And they have 2 little rooms to cater for the whole population of Gaborone and outside Gaborone. So tell me why that would make any sense at all. Why is that taking mental health serious if you're not going to really recognize that this is a place where most problems are going to come because of the population and because of migration of people from other places to this place. To Gaborone, yeah.
And so build a psychiatric hospital here, or at least a unit within Marina.
In addition to Sabrana.
In addition,
because
Sabrana is a referral.
It's a referral, yes. It can remain as a referral.
Yes.
Okay.
So it can remain as a referral more for complex cases that can be managed here. But now you have some of these hospitals, like I know I did my TS, was Sekgoma, the old Sekgoma.
Sekgoma in Molapolle.
No, Sekgoma ko Serowe.
Oh, Serowe, okay, yes.
So the old Sekgoma Memorial Hospital. There was a psychiatric unit there. The newer hospitals, they've got psychiatric units built there. And these are hospitals in villages. And yet a city does not have a psychiatric unit.
Marina hasn't got.
No. It does not have. And so people just come to the emergency department. They are given acute treatment, which is sedation if they are really unwell. And sedating people is not necessarily safe. It's unsafe. You sedating someone and then they are going in a car to, they could die on the way or there from other things. So it's just not safe. And now Sabrana is this haven that was built, and then everyone talks about Sabrana like it's going to provide.
Some people want to go there.
Yeah, and people want to go there. And I'm thinking it's not even staffed properly. They don't have psychiatrists. Enough psychiatrists. I know that people are going to say, yeah, come back home. No, I'm not. I'm not coming back home. The reason I left is because it's going to be hard for one person to change the system.
To make a difference.
So I'm just saying.
And that is why my question to say, like you said, I like what you said when I said, when you meet the president and you want to come back, what are those 2-3 criticals? And I like you to touch, because this one comes out of the media quite a lot, about recovery centers. We need more support for people who are not, so that we prevent people end up committing suicide. That's the only thing that we hear. Yeah. No, someone's died. Oh, no, we should have helped him before. Please make sure that you have those thoughts. Go see a loved one. I mean, and it's almost talk about we need to have more recovery centers for drug addiction and that. What's happening in that space?
Yeah.
Is that necessarily a solution?
Look, no. And look, I've been approached by people since the reign of President Khama to say, because there was that alcohol levy money, that people borrow money and come and build a rehab, and even people who don't even know the know-how, don't have the know-how. And I'm saying you have to be a health worker to be able to establish a rehab. Anyone can, and employ the right people. But people were saying people just wanted to have a rehab, build a rehab. No one was going to tell me why they want to build a rehab. They wanted to build a rehab because there was money that was being, allocated.
The motivation was just wrong.
Yeah, it was wrong. So there are two things about rehab. Am I saying rehabs are not needed at all? They are necessary. The big question is, one, how many do we need in Botswana in a population of 2 million people? What percentage of people are using drugs in Botswana? We don't even have that statistics clearly because we're not researching the problem. We are tackling the problem without the actual knowledge of what it is. We don't know our enemy. So do we need a rehab? Yes, we need a rehab. But before rehab, the most important thing that we need is public health education about drugs. People don't know drugs. People wouldn't even know what to use rehabs for. And people think substance use is just in the cities. Those people who just wake up in the morning, going back home. The following morning, goes back to the same place. There are those people who actually have lived with substance use for many in villages. Every village has at least 3, 5, or 4 or 10 of those. Do they know what rehab is? Have we reached out to those people? Do they know really what a rehab is and what it's meant to do? We're missing the point. We're jumping the gun. We need to start with educating the community, get the community ready for rehab. Secondly, there's the law. You can't make anyone go to rehab. You need to recognize that people who are actually addicted to drugs are struggling with a medical condition, which is addiction. One of the things that it does is it clouds their ability to know that they need help. They want it and they don't want it because they're addicted. They depend on the drugs to survive. So you're not going to get them working into rehab voluntarily. But then you can also force them to go to rehab involuntarily.
They're adults.
They're adults. There's no... And most of the time, I've worked in an addiction hospital for a very long time in Sydney. So you can't... There are some people who would not want to go to rehab, no matter what you do. So we'll build them, they'll be white elephants. And unless the legislation changes and enforces people to go into rehab when they've been assessed and found to be probably killing themselves with substances, But right now, legally, you can't make anyone go to rehab. And we'll end up doing the South Africa. A good thing he's doing, but it's not legal. Walking into somebody's house, come on, and then take them to rehab and lock them there. I guess that would help him, but human rights. We've got a human rights president. The rights of that person comes first. That's point number 2. With mental illness, we have the legislation. We've got the Mental Health Act, which is very clear about who you can admit and who you can't, and when you can admit someone and when you can't. So you still can't take anyone to Sabrana just because you want to. There's got to be medical reasons for that, which are, it's this person at risk to themselves or other people. They still have rights. It doesn't take away your rights. It's just protecting the public and your interest as the person. So the legislation needs to be revisited there around rehabs before we just jump to building them. Otherwise, as a family member, I'm just going to drag someone to rehab just because I want to, because I want them to get better. They don't want to get better. They're not ready. Secondly, the other thing is, I think people need to realize that addictions, not always, but most of the time, and I would say probably approximately 80% of the time, there are what I usually refer to as symptoms of something happening. They're indicators that there's something underneath going on. Most people who end up getting caught up in substance use may have a pre-existing mental health condition. So really, about 80% of people with mental illness use drugs.
80%?
Roughly, yeah. Around 81 if I had the...
Okay.
Yeah.
They're very vulnerable to drugs.
Extremely.
Yeah.
And their brains are very vulnerable. So they also... some people are struggling with other issues. There's a lot that's going on right now. There are political issues, there's poverty, there's unemployment, there's all these other things which need to be taken into consideration when you deal with these things. Is rehab going to help me if you want to put me there and I'm released and go back to the same conditions? I'm detoxed, I'm not using drugs anymore, I've been rehabbed, then I go back, I still don't have a job. I still don't have food. I still can't get a job. I'm still poor. You end up getting stressed and using substances again to soothe yourself.
Yeah.
The other danger, this is a very
How
tricky...
successful are rehabs in terms of relapses and sustained recovery?
It's hit and miss. And that's the other point. That brings me to the other point where I was going to say that rehabs can also be drug breeding places. In Australia, a very well-controlled, lawful country, most rehabs, people go there. And that's where actually drug dealers get their addresses and actually clients.
Because that's where they come together.
Yeah, they're there. They know where to find their customers. So... you have these people getting into rehab, they come out with a lot of phone numbers. So, which then affects the relapse or the recovery process and stuff. Yeah. So, am I saying that it cannot be done completely? No.
But you didn't answer me in terms of relapse. I mean, is it over 50%? Do a lot of...
more than 50%. More than 50% actually end up, like the hospital that I'm working in right now, although I do some addictions, but I do more of psychiatry. I see probably the same people over and over again back to hospital.
Oh.
Yeah, so it's revolving door kind of thing. I think rehab is going to be successful if the underlying problem has been treated.
Addressed, yeah.
So if not, if people are going to have to go back to the same problems, it's not going to help. It's just more of a cycle that just will never stop. I have the other point. The other thing that I want to say is that the danger of rehabs are great, but danger of just opening rehabs willy-nilly that are not controlled, they need to be tightly controlled, is that people can die in rehabs because the detox process
is dangerous.
It's dangerous. If you take someone who's been addicted to alcohol and then just make them stop alcohol cold turkey, they could die from that. The actual withdrawal process from alcohol is people can suffer a serious medical condition called delirium tremens, where they can end up with brain damage. These people would end up... I could wonder if these people who are addicted to alcohol and they haven't had their beer and is into the day, they start shaking. Yes. Which are fits. Which can get worse and actually people can die. So what is the process? What is the process? What is it going to look like? Are you just going to take people and lock them in rehab? Detox it's a medically controlled treatment.
Yeah.
It needs a doctor, it needs a nurse, nurse is going to monitor the withdrawal symptoms and then administer safe prescribed medication by the doctor to make sure that they alleviate the possibility of death from detox.
There's a lot of, from the discussions that we've had, there's lack of information, lack of research, unsure about the real picture, how it looks like, which means you just shoot in the dark.
Yeah.
And then sensationalization, where now things just blow out of control. Yeah. Somebody who was an artist dies, and all of a sudden it's on the news for 2 weeks, and then it just gone back to normal.
It's gone now. It's gone back to normal.
Yeah.
And they were a perfect example of someone who's tried and gone to rehab over and over and over and over, and really struggled, and didn't end up working out, and so goes to show how hard it is. It's not just you walk into rehab, you walk out, you're fine. It's a medical condition. Addiction is a medical condition. The brain is not functioning properly. It needs treatment. There's going to be, treatment shouldn't just be going there and it's important to use people's faith. Faith-based approaches, they're important, but it shouldn't just be the only thing that you do in there as well. There should be like proper evidence-based treatments. So if you're going to start a rehab, you need to tell people what evidence-based approaches you're going to use, not just lock doors and get people praying or doing activities without proper intervention. So I still don't know what people actually do behind those doors. The rehabs that I've worked in most of the time were clinical, were hospitals. And so there were doctors, there were nurses, we were monitoring things, we were really addressing issues. There would be individual psychotherapy, group therapy, and other things. And some people would be risky, and we know that we need to send them to other places where they'll be safe.
Yeah.
The other issue that you touched on was the issue of suicide, where I think we talked about it earlier before we started about how I don't think suicide is taken serious in Botswana.
Yeah.
I think it's just, people talk about suicide as if it's just, as if we were yawning. You can just yawn and you open your mouth and, but and then you forget that you ever even yawned, unless you make the whole room yawn. But suicide is a serious thing. And like I said, I still maintain that we are never going to get rid of suicide. It's part of the human condition. We are here. We're going to die either by diseases, by accidents. We're going to get murdered. We're going to suicide. But even with all these other things, we still try to prevent them. We still try to prevent infections, non-communicable diseases, even though we know that they are going to kill us, but we don't stop and do nothing. But my problem with the way suicide is handled in Botswana is somebody dies of suicide, and then there are two things. We're going to, now social media is the platform where people get attacked. Then this person get attacked on social media because they kill themselves, they are coward and blah, blah. And then, we find a witch who bewitched this person. And then the other thing is, I feel like the systems the government systems, I'm going to say that, is failing at addressing suicide. There has to be proper inquiry into why people commit suicide, which is independent of people who are treating them. In Australia, there's the coronial system. So every single
there's an independent body that comes and outside that.
Yeah.
Okay.
So anyone who dies mysteriously, questionably, the case goes to the coroner. Which is a legal system where there might be a doctor in there, a psychiatrist or whatever kind of specialist in there, depending on what the case is. Where the case is presented, and then we talk about why it happened, what was done what could have been done to prevent it, what was done, what worked, what didn't work. It keeps, first and foremost, all responsible people on their toes to make sure that when suicide is mentioned, they take it serious. As opposed to, it's your life, do whatever you want to do. So they come into hospital, somebody says, I'm suicidal, and then I take measures to try and address and alleviate the risk. You can't eliminate risk. Risk is just not going to be eliminated by, 1, 2, 3, 4 sessions. I've had people who've seen, been in the system, they're case managed by a nurse, they've got a psychiatrist, a psychologist, and everyone, and they still end up ending their lives. Really, if someone wants to do it, can't stop them, but something can be done, which might help. So I think the government needs to start taking suicide serious. When someone has died of suicide, it shouldn't just be they are dead. It should be why. How can we prevent the same thing happening again, and all the rest of it. So that's one of the things that
Do we have a suicide office?
I don't think we do.
You know why? Because I was looking at the statistics in 2019, I think over 300 people in Botswana died from suicides. I mean, I know from accidents about 400 and 500 or something like that per year. But from accidents, there's a whole motor vehicle fund. There's a whole, office dedicated to accidents.
Yes. Yeah, but we don't have an office like that. So we have, in other places they have suicide prevention. In Botswana, no. I don't think we have that in African countries. I think people still probably...
It's a taboo, Nyana.
Yeah, but there's still this subtle blaming of the victim that, without really knowing what they were going through for them to make... No one wants to destroy themselves like that. So the big question should be why? Why should somebody get to that point where they know they're going to come to an end and they just really do it
execute
anyway?
it,
So I think these kind of things would be addressed more if we actually do have these discourses, even when nothing has happened. Right now, I think it has now remained a social media thing.
Playbook.
Yeah,
almost.
so we go there now. Someone is suicided, some have pity, some, and then after that, like you say, after 2 weeks it stops. And then until the next one does it. Same thing with the GBV issues with murder suicide. Then people talk and talk and talk. After a week, they're quiet.
It's gone.
And then also, I don't know. I often talk about social media and mental health. That's a good and bad mix. People, would post things on Facebook. Those things could be helpful in sensitizing people. They could also be unhelpful. They can be over-sensationalizing or, creating the copycat effect. You've got this man actually to beggar teacher society and and then beating and then it then goes viral. Not many people are as smart as we think, actually. Somebody sees that and they're just gonna do it some other way. So, and then victim blaming again. Why isn't she doing anything about it? People clearly don't understand the actual issues around the so-called battered woman syndrome. A woman in domestic violence, ends up in a situation where they have you heard of Stockholm's syndrome?
Stockholm syndrome. Yeah.
So the learned helplessness, where they go and drop the case, and then
Professor Seligman, he's the one who wroght about learned helplessness.
Yes, yeah. You should have taken the exam for me. and they do that. And then also if you are threatened, and then if you do this, I'm going to kill you, I'm going to do this. And then you also have kids, you're afraid of this person going to jail, they're probably providing, and then what are you going to do? And you also know that men have been killing women, so they play victim. After beating you up, they play victim, they cry, I'm depressed, now I'm in trouble because of you, and then you go also the case. So I think instead of talking, we should have more women empowering, groups or resources, and have, women's refuge centers where people can actually go and run and hide and be protected properly.
But there has been lots of talk about those, but it's been pockets of hero individuals, underfunded NGOs, all that. I think, just in summary, it appears like this whole crisis, if we may, gender-based violence, suicides, mental health, Sabrana, recovery, it's just not pitched at the right level. I mean, I'm trying to summarize what you tell President Duma.
I think you are right. You are right. Yeah.
Or just take this thing from here.
Yeah.
If you want results and less disaster in the next couple of years, just put it at the next level and make it also, put it in your narrative as a president. Is that?
I think that is perfect. You couldn't have summarized it better. I think we need the right people addressing these issues in the right forums. Facebook is not the place to address sensitive issues. Like we can talk about them like that socially, but when it comes to the seriousness of these issues and who should be involved and how, I don't think we you're right. I think we're pitching it at the right level with the right people, right forums. And, I've attended some workshops before when I used to work for the government. And most of them were just really feeding workshops. People went there to be fed with food and sex. Just go there and then they eat throughout the day and they're living in hotels. And then I've never... When I do go to a conference where I work, I have to come back and present on what I actually... Then we talk about how this would fit our model and stuff.
Absolutely.
But it's, I guess all in all, mental health is very important. People don't like to use drugs. Even those who started off just really experimenting and got hooked, they don't like that. The majority of people who are using drugs have actually underlying mental health conditions which need to be addressed and not just the drug. Rehabs are good, but there are a lot of disadvantages that need to be taken into consideration while establishing one. Otherwise, they'll become more problematic than actually being helpful. And then you would have lost something good because we didn't do it properly. So they have to be sustainable. To be sustainable, they need to provide evidence-based treatments. And then suicide is a real thing. People kill themselves. We can't eliminate it, but we can prevent it as actively as we can. I think the other thing that came to my mind was with the rehabs was, I remember HIV and AIDS when it started. We all wanted to have organizations and getting money, and there's a lot of organizations mushroomed, and then they'll start, and then Maria from all the funders, and then gone. The organization is gone. So I see the same thing with rehabs. Some intentions are not really up. It's not about the people, it's about
just the money that comes. Yeah.
There's nothing wrong with wanting to make business out of something that is a problem, as long as you really, really want to solve the problem.
If you mean well.
And so that is...
No, thank you very much. That's really rich. You've shared a whole lecture.
I know. I like to talk too. I like listening to the sound of my voice.
I let it be because, as we said, it's a conversation that needs to be held at national level, even at district level. In terms of different. Different districts in Botswana have got different socio-economic issues. When you look at the poorest areas in the northwest and the Kalahari, where there's a lot of addiction, affecting even groups that have been sidelined for a very long time. So the dynamics are quite different. Just like we went at the Southern African level, where Lesotho is a hotbed of suicides. Why? I don't know. But so every situation has got its own answer. So I just hope that we've managed to illuminate some of these issues for our viewers. And I really, really appreciate it in terms of those insights. And I hope the powers that be are listening. But importantly, it starts with the individual. And then I hope in terms of unpacking, like we said, some of us don't even know whether we actually have mental health issues.
No.
Just because psychotherapy, those things, as far as I'm concerned, should be pervasive in a society. It should not be expensive. It should not be for a matter of those that can afford it. Because we all need support. And it's not because it's fashionable, it's because our old cultural, structural supports are not there anymore. The uncle is not there anymore down the village. The friend on the other side is not there to go chat. Those things are not there. So now, professionally, they can be provided by professional therapists. So those are the things that I hope, as a viewer at home, you pick those things up. And then let's please appreciate Dr. Ntsowe, who came all the way from Australia to share. And we hope that with some of the big points that he said, if President Duma addresses this and that, I'll come back. Hopefully he will come back.
Yes, I definitely will. If I got a phone call and they said, look, we're addressing 1, 2, 3, 4 things, and there will never be any shortage of medication. There are medications. The Botswana would be a safe place to practice. I don't want to leave this world with a bad legacy, professional legacy, where I wasn't able to help my people.
Absolutely.
And just to set the record straight, I know people are going to say, what if I say all these things when he's, one, I did work here and I still do support
the
people
system
here.
Yeah.
I still do educations, monthly educations. A lot of people have attended my Zoom. It's just on Zoom.
Yeah.
Once
free webinars. You do webinars, you said.
Yes, free, and it's all free. And then I still support a lot of psychiatric nurses, giving them advice on how to treat patients. Some of them have actually even gone to the extent of assessing the patient myself online. But I still do things for my country.
Well done.
Thank you.
Great stuff. Thanks very much.
Thank you.
Andrew.
Thanks,
it's been a pleasure.
Yes.
Thank you. There we go, colleagues. I hope you enjoyed the insights. And again, as usual, please share as much as you can. This mental health issue is something that's really troubling the country, it's troubling the region, it's troubling Africa. It's even a global matter. So through the GrowthWell podcast, we want to elevate this type of issues, and hopefully the parts that we are listening and some of the insights and the proposals that come from our expert guest today can find fertile ground. So thank you very much and see you next time.